Good morning, everybody, and welcome. My name's Sophie Scott. I'm the medical reporter for ABC, and I'm going to be your host for this event today. I'd like to acknowledge the traditional owners on the land where I'm coming to you from, the Cammeraygal people of the Eora Nation, and welcome you to the launch of the 4th Australian report into antimicrobial use and resistance in human health. I'll come back to you very soon with more details of our event today, but to kick things off, I'd like to throw over to Professor Villas Marshall, who is the chair of the Australian Commission on Safety and Quality in Healthcare board, to officially open our event. Please welcome Professor Villas Marshall AC.
Thank you. Thank you, Sophie. I would like to acknowledge the traditional owners and custodians of all the lands on which we meet today and pay my respects to elders past, present and emerging. I'm joining today from Adelaide, which is located on the traditional country of the Kaurna people of the Adelaide Plains. Welcome, and I thank you all on behalf of the Australian Commission for Safety and Quality in Healthcare for joining us for the launch of AURA 2021. The 4th Australian report on antimicrobial use and antimicrobial resistance in human health. Since its establishment by the Commission in 2013-14, the AURA surveillance system has provided an increasingly comprehensive picture of antimicrobial resistance and antimicrobial use and the appropriateness of antimicrobial prescribing across the acute and community centres in Australia. The AURA surveillance system relies on contribution of data from the public and private sectors across Australia. This contribution is much valued by the Commission, and we hope that you in turn gain a great deal of value from the reports at a local level. Antimicrobial resistance is a significant public health and patient safety issue, which is driven by the overuse and misuse of antimicrobials, and the data and information for AURA 2021 will be an aid to us all in preventing and controlling AMR. The findings and trends presented in AURA 21 are encouraging in many areas, but there are still areas of concern, as you will see from the report. We have an impressive lineup of speakers and panellists who are experts in these fields and who lead the surveillance partner programs that contribute data to AURA. We are fortunate to have such outstanding clinical leaders engaged in improving patient care with us today. They are going to provide us with an overview of the findings and their implications for clinical practice and policy, and discuss what we can all do, and I stress all do, to prevent and control antimicrobial resistance. I'll now hand you back to Sophie.
Thank you very much, Professor Marshall, and it's great that we can do this even though we're not in the same room like we normally would be, but it's great we can do this in the digital space and have so many people watching. So I'd like to now also thank everyone in the audience for taking part. We know that you're really busy, everybody, and we really are so grateful you've taken the time to be part of this event. Now, if you're on social media, we would love you to tweet out about what you're hearing. On Twitter, you can follow the Commission and please tag the Commission in any of your posts. So their Twitter handle is all just capital letters ACSQHC, and mine is Sophie Scott and the number 2. And if you're on Instagram as well, you can find me over at Instagram on the same handle, so Sophie Scott and the number 2. But Twitter's great for this because there's lots of people interested in this area who are on social media, so I would love you to get the message out about the findings of this report in particular. So we're going to hear some amazing and really interesting new insights and data that's coming out in this report, and I'll just give you a little snapshot of what we might be hearing without giving all the good stuff away. The report projects that more than 10,000 people will die between 2015 and 2050 from antimicrobial resistance. And while the use of antimicrobials has decreased in primary care, as you'll hear, there's still more than 10 million Australians, or 40% of people, had at least one prescribed in 2019. And that's a much higher rate than countries like in most European countries and also in Canada. And as Professor Marshall mentioned, we have a distinguished list of speakers who are really going to unpack a lot of the detail of this important report. And then in the panel discussion, we'll go into it in even more detail. And even though we're dealing with COVID at the moment, antibiotic resistance is still one of the biggest public health challenges that we face. And that's absolutely no doubt about that. And to kick us off and get the event rolling, I'd like to introduce a message from the Deputy Chief Medical Officer and Principal Medical Advisor to the Australian Government Federal Health Department, Professor Michael Kidd, AM. And now we'll hear, please welcome Professor Michael Kidd.
Hello. I acknowledge the traditional owners of the land where I am standing today, the Ngunnawal people. I also acknowledge the traditional custodians of the lands and waters where you are, and I also acknowledge all Aboriginal and Torres Strait Islander people participating in this online broadcast. I pay my respects to elders past, present and emerging, and celebrate the diversity of Aboriginal people and their ongoing cultures and connections to the lands and waters of Australia. Thank you for inviting me to participate in the launch of the 4th Australian Report on Antimicrobial Use and Resistance in Human Health. My congratulations to Professor Deborah Picconi and her team at the Australian Commission on Safety and Quality in Healthcare on the release of this important report. The COVID-19 pandemic has overshadowed so much of our lives over the past 18 months and has drawn attention and effort away from many other critical issues. Antimicrobial resistance is one of these issues. However, antimicrobial resistance has certainly not been forgotten. Antimicrobial resistance remains a significant health concern nationally and globally. While we have had to focus much of our energies on responding to the pandemic, there have been several significant positive developments as part of the implementation of Australia's National Antimicrobial Resistance Strategy for 2020 and beyond. This was endorsed by the Council of Australian Governments and released in March 2020. The publication today of the 4th Australian Report on Antimicrobial Use and Resistance in Human Health, AURA 2021, is one of these important developments. The data in this report highlights important areas for action. While antimicrobial use has decreased in primary care settings in Australia, in 2019 more than 10 million people in our nation had at least one antimicrobial dispensed under the PBS or the Repatriation Pharmaceutical Benefits Scheme. This is much higher than the rates seen in most European countries or in Canada. Antimicrobial use has increased in our hospitals and there's been no improvement over time in overall appropriateness of prescribing. Inappropriate prescribing of several broad-spectrum antimicrobials was identified in 2019, including cefalexin, cefazolin, azithromycin, and amoxicillin clavulanic acid. The three indications with the most inappropriate prescribing were chronic obstructive pulmonary disease, surgical prophylaxis, and surgical wounds. The trends for chronic obstructive pulmonary disease prescribing require urgent intervention as non-compliance with guidelines continues to increase. There are also no significant improvements seen in antimicrobial use in residential aged care services between 2017 and 2019. These findings highlight the importance of continuing work to reduce inappropriate antimicrobial prescribing and use in hospitals, in residential aged care, and in primary care. We do know, however, that the COVID-19 pandemic has had an impact on antimicrobial dispensing rates. In 2020, there were substantial decreases in dispensing rates for several antimicrobials, including amoxicillin, cefalexin, and doxycycline. This decrease in dispensing, likely mainly for seasonal respiratory infections, has coincided with pandemic control measures such as physical distancing and improved hand hygiene practices and a reduction in respiratory infections in the community. There will be continuing opportunities over coming months and years for further interventions to sustain these lower levels of antimicrobial use for conditions for which antimicrobials are not generally recommended. The AURA surveillance system has played a significant role in providing a comprehensive picture of patterns and trends in antimicrobial resistance and usage in Australia, improved our understanding, and provided essential information to inform our strategies for preventing and containing antimicrobial resistance across our country. Understanding trends and current issues in relation to antimicrobial resistance and usage helps to ensure that people in Australia are being offered appropriate antimicrobials to treat infections, and that infection prevention and control measures are based on the best available evidence. The Australian Government Department of Health continues to support this important initiative as one of the priority areas under the Australian National Antimicrobial Resistance Strategy for 2020 and beyond. The National Antimicrobial Resistance Strategy has strengthened calls for a shared responsibility across the health, agriculture and environment portfolios. It also highlights enhanced collaboration between the Commonwealth and states and territories to ensure a more unified national approach to addressing antimicrobial resistance in Australia. In the October 2020 federal budget, the Australian Government committed $22.5 million over the next 4 years to continue surveillance of antimicrobial usage and resistance. And this includes funding to develop a One Health antimicrobial resistance and usage surveillance capability. To that end, the Australian Government Department of Health has been working closely with the Australian Commission on Safety and Quality in Healthcare to transition towards One Health surveillance. As a first step, management of the surveillance programs that contribute to the AURA surveillance system were transitioned from the Commission to the Department of Health at the start of this year. I take this opportunity to commend the Commission for establishing and operating the AURA surveillance system over past years and for the Commission's assistance in facilitating the smooth transition of antimicrobial resistance and antimicrobial usage surveillance activities to the Department of Health. I also commend the Commission for its significant efforts in preparing substantial antimicrobial resistance data as part of Australia's contribution to the World Health Organisation's global antimicrobial resistance surveillance system this month. This will help inform global understanding of antimicrobial resistance. The overall goal of Australia's national strategy and the purpose of the funding that underpins it remain the same: to minimise the development and spread of antimicrobial resistance and to continue to ensure the availability of effective antimicrobials. I'm also going to provide some information on the development of the One Health surveillance system. A major development under the national strategy is the establishment of a nationally coordinated One Health surveillance system that integrates antimicrobial resistance and usage data from human, animal, plant, food and the environment. The Department of Health has commenced work on this project and has secured the services of Allen & Clark Policy and Regulatory Specialists Limited to develop options for this surveillance system and a transition plan to guide its establishment. A nationally coordinated One Health surveillance system will assist us in understanding the magnitude, distribution and emergence of resistant organisms that could put human and animal health at risk and affect the safety of our food supply. Knowledge gained on linking antimicrobial resistance and usage where possible across all sectors will be used to support policy development, to prioritise actions and resources, and to inform Australia's advocacy position in trade-related forums. A critical component for the success of this project is extensive stakeholder consultation, which will be particularly important to understand sensitivities and barriers in all One Health sectors and across jurisdictions to ensure implementation of effective governance arrangements. The One Health surveillance system will build upon existing systems, strengthen networks, and refocus our priorities towards data for action at local, state, territory, and national levels. We need to ensure that we retain the best elements of our existing approach to human health, think about what improvements we can make, and ensure that the new One Health surveillance system meets the needs of all sectors with an interest in monitoring antimicrobial resistance in Australia. I suspect that under this nationally coordinated One Health surveillance system, those of us who deal with antimicrobial resistance in human health will be working much more closely with our colleagues in the animal health, agriculture, food production and environmental health areas under this new approach. So in conclusion, the potential impact of antimicrobial resistance makes it one of the most pressing health problems we face, nationally and globally. For me, it remains a top priority alongside our response to COVID-19. I expect that everyone listening to this broadcast feels the same, and I encourage you to continue working towards and achieving our shared antimicrobial resistance goals, and to let your actions be informed by the Australia-specific data presented in the report we are launching today. In government, we'll be referring to this report and using the national strategy as our principal guides to taking action on antimicrobial resistance over the next few years. I hope that you are able to align your efforts and resources to the objectives and priorities set out in the national strategy, and that together we can make a difference, because we really need to. Thank you all.
Thank you very much, Professor Keard. We really appreciate you taking the time to do that report, that video recording for us. Now, it wouldn't be a launch of a report into antibiotic resistance without our next guest, Professor John Turnidge AO. He's the Senior Medical Advisor on AURA at the Commission on Safety and Quality in Healthcare. He's also the Scientific Secretary of the European Committee on Antimicrobial Susceptibility Testing, a clinical professor at the School of Health Sciences at the University of Adelaide, and he's played a key role in not only this report, but many other reports into this important health issue. So please welcome Professor John Turnidge, AO.
Welcome to a presentation on the key findings of AURA 2021. First of all, we'd very much like to thank all of the AURA contributors and partners, including all the state governments, the federal government, and all the support organisations run by those governments and by academia. Thank you for the fantastic data I'm about to show you. Just to let you know, there are some new features in AURA 2021. We've been able to analyse data over a longer period. We now have data for the first time on resistances from the Northern Territory. We were able to take a first look at the effects of the pandemic on community prescribing. We've been able to take a deeper dive into the appropriateness of use in the community, look at private prescribing in the community, and have a first inclusion of data on the important pathogen Clostridioides C or C. difficile. Just to outline what to come, we are going to deal with community use, trends, pandemic effect and appropriateness, hospital antimicrobial use, including trends, volumes of use and appropriateness of use, as well as resistance rates to some of the important pathogens and some trends, and some critical antimicrobial resistances will be covered briefly towards the end. Finally, we'll talk about important areas of action that the Commission and the report have been able to identify. Let's start off with community use. The good news is that we've been observing over the last 5 years a steady decline in use in the community as identified by the Pharmaceutical Benefit Scheme prescriptions, which accounts for more than 90% of all the prescribing in the community. However, those figures are still high. When we compare ourselves to European countries and to Canada, we can see that we're still up there at the high end of usage in the community, and we would very much like to head toward the benchmark country, which is the Netherlands, which is about half of the community use rate that we observe here in Australia at the moment. One of the problems that we identified in the recent past was the automatic repeat prescriptions that came with GP's desktop software. Fortunately, the Pharmaceutical Benefit Scheme people have addressed this problem in part and introduced restrictions on repeat prescriptions for 4 common agents from April 2020. Those agents are amoxicillin clavulanic acid, ephelexin, and roxithromycin. When we look at our Medicine Insight data, we also notice the same downward trend, so it's good to have that confirmed with an independent data set. However, one thing we have picked up in the Medicine Insight data is a slow and steady rise in the use of private prescribing to get access to some restricted antimicrobials on the Pharmaceutical Benefit Scheme. This is a bit of a problem because private prescriptions aren't documented, so it's only Medicine Insight data that's been able to give us an indication of what's been happening here. We hope that that will be addressed with data capture in the future. The most valuable part of the Medicine Insight data is identifying unnecessary use in the community. And we've been able to do that by documenting the use of antimicrobials in conditions such as acute bronchitis, acute otitis media, and acute tonsillitis, where we expect very low prescribing rates or even zero prescribing rates when we use our benchmark guidelines, therapeutic guidelines, antibiotic. And you can see we should be prescribing at rates of 0 to 20 or 30%, but we're observing rates of prescribing that could be anywhere as near as 80 or 85%. One thing we did discover in the data set from the Pharmaceutical Benefit Scheme was the effect of the pandemic on prescribing. This was not entirely expected, given the high use of antibiotics for respiratory tract infections in the community. But the effect was very observable. After a brief period of what looked like stockpiling in March 2020, there was a dramatic drop in overall prescribing in April 2020, which has been sustained through to the end of the year, and we hope sustained into 2021. None of this can be attributable to changes in access to repeat prescriptions or to the number of attendances in GP, but we do know that where the effect was most frequently observed was in upper respiratory tract infections, and clearly the number of respiratory tract infections with social distancing and other COVID control measures has had a significant impact on attendance of GP for this condition. What's happening in our hospitals? Well, unfortunately, we're seeing the opposite trend, and we've seen antimicrobial use go up in our hospitals despite our best efforts. We believe that some of this can be attributed to increasing data capture, but probably not all of it by any means, and we will need to investigate further why usage is going up. It may also be a reflection of the measure that we use, which is in defined daily doses per 1,000 occupied bed days. In future, we hope to have days of therapy as a better indicator. When we try and compare ourselves with other countries, the back of the envelope calculation suggests that the usage is very high in Australia compared to European countries or Canada. We're not sure how real this is, but it's certainly very suggestive that there is a problem. When we look at appropriateness of use of our antimicrobials in hospitals, we turn to our NAPS program, National Antibiotic Prescribing Survey, and see that the trend in appropriateness of use, the bottom line in the table, has not really gone downwards, despite ever-increasing antimicrobial stewardship. There have been small improvements in some other items, such as review or stop date. However, that overall summary hides the detail. We have seen improvements in principal referral, public hospital groups A, B and C, and in women's and children's hospitals, somewhat counterbalanced, unfortunately, by no change or deterioration in acute public hospitals, Group D, and in private hospitals. So clearly, this will help us address those sectors in terms of improving antimicrobial stewardship. One thing we did notice was the very high non-compliance to national guidelines for the treatment of pneumonia, and especially chronic obstructive pulmonary disease. There's clearly large room for improvement there. What's happening on the antibiotic resistance front? First, our most common and important pathogen, Escherichia coli, E. coli, still has significant rates, if not increasing rates, to ceftriaxone, third generation cephalosporins, and to fluoroquinolones, whether we look in blood or urine. Those rates are even higher when we look in Northern Australia, and we can see those rates rising in that particular sector as they are in the rest of Australia. Rates have been, to these particular classes, the fluoroquinolones and ceftriaxone, have been quite low or in the middle of the pack for some years, but we can see a rise from low to getting up there with fluoroquinolones, and a sort of stable situation, more so with ceftriaxone. What about vancomycin-resistant Enterococcus faecium? Well, the good news is, after having very high rates compared to many other countries, almost all other countries, with this, we are now starting to see a decline over 5 years, and that decline is very encouraging. This is a resistance that we were very much hoping we could contain, and it looks like we are slowly getting on top of it, although we would clearly like a long way to go to get to the levels seen in Scandinavia or other European countries. What's happening in the gonococcus, Neisseria gonorrhoeae? Fortunately, resistances have been quite stable. We were a bit concerned about rising resistance to azithromycin, the yellow line at the bottom of the graph. That kept increasing to 2017, but by 2019 was in decline again, probably due to changes in circulating clones. Ciprofloxacin resistance in Salmonella typhi, though, is a totally different question. Almost all typhoid cases are imported in Australia, and we believe we're importing more and more resistant strains from other parts of the world. And this agent, ciprofloxacin, used to be the drug of choice, but is no longer considered appropriate first-line therapy and shouldn't be used unless we know it's susceptible from laboratory testing. Another important resistance in the GI pathogen Shigella, Shigella flexneri and sonii, both having worrying rises in resistance to different antimicrobials, but particularly to ciprofloxacin and cotrimoxazole in the sonii strains. What's happening in Staphylococcus aureus? We're most worried about resistance to oxacillin, and that a marker of methicillin resistance, or MRSA. It's running around 17% in Staphylococcus aureus around the country, in blood culture isolates and similar for other specimens. When we look in Northern Australia, though, the rates are even higher, well above 20%. You can see it's well above 30% for skin and soft tissue infections. So this reflects the fact that some clones become very common in our regional, remote and Indigenous communities. Staphylococcus aureus rates compared to, in Australia compared to other European countries are around about the middle of the pack, and may or may not be rising depending on how you read this graph. We do have two major circulating clones. One is healthcare associated and a problem in our hospitals and our aged care facilities. That is ST22 or EMRSA15. And in the community, we have a dominant clone now over the last 20 years, the Queensland clone or ST93. There are differences between the jurisdictions in rates of MRSA that are of some interest. On the eastern seaboard and in South Australia, we generally have similar rates of MRSA, a bit higher in Western Australia and a lot higher in Northern Territory, probably due to high rates of community-associated strains in regional, remote and Indigenous communities, and pleasingly lower rates of resistance in Tasmania. Finally, we'll talk about resistance in Group A strep. We didn't expect to see emerging resistance, but clearly emerging resistance now to the macrolides, erythromycin and to clindamycin, and this takes away one of the important support therapies for treatment of infections caused by this pathogen. We do want to mention, of course, Clostridioides difficile. Our first look at detailed data provided to us by the surveillance program run out of the University of Western Australia shows that there's little or no acquired resistance to C. difficile at the moment, and we hope it stays that way. In terms of critical antimicrobial resistances, the dominant problem in Australia are carbapenemas producing Enterobacterales, or CPE. As you can see, in 2019 and 2020, the rates have not got worse, which is very pleasing. We haven't run into the same problems as other countries. And in fact, there appears to be a decline in 2020, which may be due to the pandemic. We're not really sure at this point. When we have to treat Enterobacterales that are carbapenemase producers, we often have to use the last line antibiotic colistin. Acquired resistance and transmissible resistance has emerged worldwide with the MCR genes in this particular species. And we're now tracking those in our CAR-Alert program, but we see no significant changes over time, which is again also pleasing. Finally, let's finish up with areas for action. We have identified five areas for action. First, reviewing prescribing practices in light of current and emerging resistances and to inform guideline development, which we will be doing with the Therapeutic Guidelines Inc. We would like to improve appropriateness in prescribing of COPD and engaging with NPS medicine-wise in interventions in this area. We would like to see improvements in appropriateness of use in primary care, and particularly to sustain the downward effect of COVID in inappropriate prescribing for respiratory tract infections in our community, and engaging with our partner, the Commonwealth Department of Health. We would always want to see appropriateness of prescribing improve in residential aged care. Throughout the life of the AURA program since 2016, we've identified problems in that area. And finally, we would like people to consider CDI surveillance at the laboratory level to be a major program to be integrated into AURA into the future, and to support the national program that's currently run out of the University of Western Australia. So thank you very much for your time, and I will now hand back to our moderator.
Thank you very much, Professor Turnidge. We really appreciate your insights, and we'll be hearing a bit more from you when we get to the panel discussion. And talking about the panel discussion, if we've got lots of questions that you all put in when you registered for the event today, which is great. But if you think of something and you'd like to ask a question, you can see that there's a little blue hand icon. So please feel free to jump onto that and ask a question. We'll try to get to as many of the questions as we can. But we've only got a limited time. We'll try to get to as many questions as we can. So now moving on, we're going to now look at the appropriateness of antimicrobial use. What do we know now in this latest report? What is it telling us? And I'm delighted to introduce Professor Karen Thursky, the Director of the National Centre for Antimicrobial Stewardship. She's an expert advisor to the Commission with her team at the Royal Melbourne Hospital, and she leads the National Prescribing Survey, which is a key contributor to the National Surveillance Program. So please welcome Professor Karen Thursky.
Thank you to the AURA team for the opportunity to briefly overview the appropriateness of antimicrobial use across our hospital and community healthcare sectors. Australia is in a very unique situation because we do have a rich source of data coming from the National Antimicrobial Prescribing Survey. Appropriateness beyond guideline compliance is being used to drive activities in both hospitals and in the aged care sector. The NAPS helps sites meet the clinical care standards for antimicrobial stewardship as well as accreditation, and the flexible audit methodology supports deep dive audits, particularly when NORSP reports show high use of particular agents. The most popular aspect of the NAPS is, of course, the pre-formatted reports, and this is hugely important, particularly in regional remote hospitals without access to EPN stats. The data from NAPS has contributed to AURA since 2015 and will be a key component in new jurisdictional strategies. AMS research programs such as allergy delabelling, paediatric stewardship and surgical prescribing have utilised the NAPS program in their designs. And we will also see antifungal NAPS launched later this year, which is really exciting. Finally, we have demonstrated that the NAPS methodology is actually feasible and translatable in both developed and low and middle income countries. Key indicator data from the hospital NAPS up until last year shows that there certainly is better quality of indication and review and stop date documentation, and this may reflect the activities of AMS programs as well as the increased implementation of electronic medical records. But we can see that surgical prescribing, which is the most common indication, remains a major area of improvement, but this is better explored with the SNAPs. We consistently see a gap between appropriateness and guideline compliance, and it is worth examining this in more detail. This slide shows that even despite COVID-19, we have seen increasing participation, especially in regional and rural hospitals, which is fantastic. And we also see that there have been real gains in appropriateness across the different areas. And the AURA report showcases a couple of wonderful examples of AMS programs that have utilised hub and spoke, telehealth and virtual models of care. We also know that the antimicrobials that are most poorly prescribed are the repeat offenders, with cefalexin, cefazole and ceftriaxone leading the pack, but also extended spectrum beta-lactams. And another interesting observation from the NAPS data is that serious infections typically requiring infectious diseases review or antimicrobials that are part of a medical prophylaxis protocol are associated with high rates of appropriateness. The surgical NAPS provides a deep dive look to see how antimicrobials are prescribed across the whole surgical pathway, and naturally it's fairly popular in private hospitals, with increasing participation even in day surgery settings. However, it is fair to say that there is significant room for improvement, and this is true for across all surgical craft groups. The quality of documentation around the time of incision and timing of antimicrobial administration needs improvement. We also see emerging use of topical antimicrobials that, although they are a small proportion of overall use, are commonly not indicated. During the postoperative phase, we see extended duration in both 24 and 48 hours, and this is a key target for action. However, changing surgical prescribing patterns will actually require a multifaceted approach, and there's no doubt that the availability of data around surgical outcomes in relation to the quality of perioperative care will be required to facilitate improvements amongst prescribers. When we look at primary care, there has been some reduction in total number of prescriptions in the community. The targets, however, have remained unchanged. High rates of prescribing for infections where antimicrobials are typically not required, such as acute bronchitis and tonsillitis, continue to be demonstrated in the Medicine Insight data. And although there has been new levers to reduce repeat prescriptions, these are still an issue. Cefalexin, despite not being the first choice indication for any infection in the absence of allergy, remains a key target, as well as the use of broad-spectrum penicillins such as amoxicillin clavulanate. There's also been a concerning rise in the use of private scripts for azithromycin and ciprofloxacin. Most GP prescribing systems readily direct the prescriber to the MIMS rather than the ETG. And so in our GP NAPS pilot, we demonstrated very great difference in guideline compliance with the two data sources. It's also fair to say that our GPs are very willing to participate in audit and feedback as long as it is feasible and practical. But they also need better access to appropriate decision support and resources. In the aged care sector, we have seen significant increase in participation across Australia. And in the 2019 survey, we surveyed over 32,000 residents. The challenges around access to trained nurses and pharmacists in the aged care sector have been well highlighted during this COVID-19 pandemic, and so, not surprisingly, there have been very few changes since 2016 in the ACNAPS data without adequate resources. Nurse-led clinical pathways for the diagnosis, treatment and prevention of respiratory infections, skin and soft tissue infections and urinary infections are really required, and I suspect that this will lead to more judicious use of antimicrobials in these areas, particularly urinary prophylaxis, reduce the volume of topical antimicrobials and hopefully improve the quality of documentation and communication with prescribers. So this is a very quick overview. Please have a look at the NCAS website, follow our Twitter feed and have a look at the NAPS for access to all our previous reports, and I hope you enjoy the rest of the day.
Thank you very much for that, Professor Thursky. Now to look at what changes we've seen over the last few years in clinical practice. We're delighted to have Dr. Morgan Warner with us. She's an infectious diseases physician and clinical microbiologist and the chair of the South Australian Expert Group on Antimicrobial Resistance. Please welcome Dr. Morgan Warner.
Hello everyone. My name is Morgan Warner and I'm a microbiologist at ASAP Pathology and an infectious diseases clinician at the Queen Elizabeth Hospital and the Royal Adelaide Hospital in South Australia. I'm delighted to be speaking at the launch of the fourth AURA report. This report, like the previous ones, provides an overarching view of the state of antimicrobial usage and resistance, as well as providing an insight into where antimicrobial prescription could be improved. I chair the South Australian Expert Advisory Group on Antimicrobial Resistance, where one of our key areas of interest is supporting antimicrobial stewardship across the state. AURA data provides systematic, coordinated and centralised national reporting on antibiotic use, resistance and appropriateness, allowing benchmarking with other states. I'd like to highlight a few things in this year's AURA report and provide some examples of how the data might support AMS practice. For the first time, AURA has categorised and reported antimicrobials on the basis of their potential to facilitate antibiotic resistance. Those antimicrobials classed as access are those with low AMR potential and which are first-line treatments for common infection or second-line treatments with low resistant potential. The curve category includes antimicrobials recommended as first-line or second-line agents for common infections despite higher antimicrobial resistance promotion potential, and antimicrobials used for prophylaxis as opposed to treatment. The contained category includes antimicrobials with high AMR potential that are not recommended as first-line treatment or are some of our last-line therapies for resistant organisms. And this shows you how those antibiotics are categorized. Of note, there are some very commonly used antimicrobials in the middle curve category, for example, Augmentin, Kepalexin, Ceftriaxone, and Piptaz. And some of these are a good target for AMS activities. This graph shows how you can categorize the various antimicrobials and gives a snapshot of the different states and the varying antibiotic use. The red stripe of the most restricted antimicrobials in the contained category is thicker for some states and others, likely reflecting a higher burden of antimicrobial resistant organisms treatment or different case mix. The graph on the right looks at tertiary and higher acuity hospital usage, and as you can see that there is some significant variation in the antibiotic usage in these different groups, with the contained category varying from 0.5 to 12.7% of usage of all antimicrobials. Interestingly, amoxicillin, clavulanate, and Piptaz on average accounted for about 40% within the curve antibiotic category. NAPS data shows us that penicillin beta-lactam inhibitor combinations within the contained priority groups are frequently inappropriately used. It's therefore useful to look at longitudinal antimicrobial usage data to look for patterns of use and consider possible explanations, interpretations, and interventions. This figure shows usage for Augmentin and Piptaz over time with significantly different patterns in each state. IV amoxicillin clavulanate became available in Australia in late 2016, early 2017, as you can see with the blue lines. But then there was a global shortage of Piptaz, leading to dips in Piptaz usage, more dramatic in some states than others. For example, in New South Wales, Piptaz usage dropped during the shortage, and I understand through strong stewardship efforts, sustained decrease in Piptaz use over the baseline was retained. In South Australia, Despite increasing use of amoxiclav, there was no concomitant sustained decrease in pip/TAZ once the pip/TAZ supply was reinstated. And we think that this is partly explained by challenges in restricting access to pip/tazocin on introduction of automated drug dispensers in one of our larger hospitals, which reduced pharmacy control on our supply of restricted drugs. So this is now an ongoing area for stewardship activity. Norse interestingly reported the use of selected topical antimicrobials from 2019, and this report showed that South Australia had a much higher use of mupirocin than other states. Some hospitals in other states did not report topicals, so South Australia may not have been such an outlier, but nevertheless, it's useful to identify reasons for variations. Breaking down the data further, as you can see in the graph on the right, that almost all of SA use of mupirocin was in intensive care, and this was also the same for Tasmania. The main reason for its use in South Australia was that the Royal Adelaide instituted universal decolonisation protocol with nasal mupirocin and chlorhexidine washes in the ICU from 2014 in response to high rising MRSA rates. And as you can see from the graph, there is the universal decolonisation strategy resulted in or was associated with a maintenance of a pre-existing decline, particularly in MRSA rates. The additional effect of moving to a new hospital was most evident with BRE colonisation. Of course, whenever you have an intervention such as this, it's important to see what the effects are in terms of susceptibilities of the newer agents. And one of the things you can monitor, and which we did do using our APAS data from assay pathology, is to look at mupirocin resistance. And really that hasn't changed. And if you particularly look at the Royal Adelaide ICU in comparison to another network hospital, QEH, the rates of mupirocin resistance remain quite low. So in summary, using ORA data to evaluate antimicrobial usage can be very useful. Evaluating in particular variation in usage to direct targeted evaluations can be very helpful. One can always use this data to consider your effectiveness of your interventions and also to evaluate and monitor for unintended consequences. Thank you very much.
Thank you very much for that, Dr. Warner, and you'll hear more from Dr. Warner in the panel discussion. So don't forget, if you've got any questions, make sure to pop up to the little blue hand and you can ask a question. Now we're going to have a look at briefly at a unique program called Hotspots, and the developer of this program is Dr. Teresa Wozniak. She leads the Antimicrobial Resistance Surveillance Group at the Menzies School of Health Research. And as she'll explain briefly, Hotspots is an analytical surveillance platform that delivers data to clinicians on evolving antimicrobial susceptibility. And she leads the recently established Antimicrobial Academy as well, Dr. Wozniak, which is a training academy for Indigenous healthcare workers. So please welcome Dr. Teresa Wozniak.
Thank you for the opportunity to present data from the Hotspots Disease Surveillance Program today that I lead at Menzies School of Health Research. I'm currently on the Turrbal and Jagera land, and the work that I will present to you today occurred whilst working and living in Larrakia country in Northern Territory. As many of you know, Northern Australia has an exceedingly high burden of infectious diseases and the added complication of resistant infections. Because of this high burden, we have a high use of antibiotics, which further emphasises the need for good stewardship in this setting. The region is challenged by difficult access to health service and many workforce challenges. But despite these, appropriateness of antimicrobial use is high, and studies have shown that narrow-spectrum antibiotics are frequently used in remote clinics. Look, it's an amazing part of Australia, but a challenge for antimicrobial resistance specifically. The Hotspots surveillance program is a laboratory-based phenotypic surveillance system that delivers synthesized data on evolving resistance. The data are accurate for local needs, up to date, and now with the recent development of a digital surveillance platform, as you can see on the screen, it will become more readily available at point of care. The Hotspots program collects susceptibility data on 13 key pathogens across 4 pathology providers and regions which are represented on this slide in colour. And we are also starting to have data provided from other regions outside of Northern Australia, as you can see on this map. data received from both community and hospital settings, which is quite a unique feature of hotspots. The AURA 2021 report presents data on the 4 top-ranked pathogens, and today I'll briefly provide an overview for Staph aureus and E. coli only. So overall, more than 88% of Staph aureus isolates are resistant to benzopenicillin during the past 5 years that the data is presented in the report. The vast majority of samples of Staph aureus were from skin and soft tissue infections, and the rates of MRSA were relatively steady across all regions. Although, if we do look more closely and break it down by setting, we can see notable differences in the proportion of community and hospital infections across the 3 jurisdictions of Northern Australia. We can see here far north Western Australia had the highest rates of MRSA, represented on the left side of the slide with the brown line. Community onset MRSA in far north Western Australia has been increasing over the past 5 years, which is a worry. Northern Territory, on the other hand, has seen stable MRSA rates in hospital over the past 5 years and a decline in community MRSA. In far north Queensland, there was a steady decline in the proportion of MRSA from community settings. And in fact, in 2019, we saw that community onset MRSA was lower than that in the hospital setting. Other work that we've done within the Hotspots program relating to the epidemiology of Staph aureus shows that a quarter of all and as much as 35% of MRSA blood isolates, as you can see here with the pointer, in the Northern Territory were actually resistant to inducible clindamycin. So clindamycin resistance in MRSA is a worry and is high in these regions and clearly impacts local empiric use of this agent for community MRSA. Now, if we turn to E. coli, we've seen that over the past 5 years, there has been an increase in resistance to ceftriaxone and fluoroquinolones, and the highest rates of ceftriaxone and fluoroquinolones resistance in E. coli are in far north Queensland. Fluoroquinolone resistance in E. coli is higher in hospital than in community, but the increase over the past 5 years has been most steep and, in fact, a doubling of proportion resistance in community settings. So if we compare the data from Northern Australia to national statistics, we can see that MRSA is far more prevalent in the north than the rest of the country. As much as 47% of clinical Staph aureus isolates in far north Western Australia are resistant to methicillin. But there is a changing epidemiology of MRSA in community versus hospitals. And we can see that Northern Territory and recently far north Queensland, there's been a decline in community MRSA, which is good news. E. coli, on the other hand, fluoroquinolone resistance is similar to national averages and sits on approximately 15%, but resistance to third generation cephalosporin is higher in Northern Australia than we see nationally. These differences show that it's important to ensure treatment guidelines are informed by local antibiotic susceptibility data, and the Hotspots surveillance program provides this data at the point of care and serves as an adjunct to clinical guidelines. Before I finish, I'd like to acknowledge the Hotspots Advisory Committee, the pathology providers across Northern Australia, without whom this would not have been possible. The program is funded by NHMRC funded Hot North program. I have a fellowship from the Prize Group, and clearly Menzies School of Health Research need to be acknowledged. I'd like to thank also the Australian Commission on Safety and Quality in Healthcare for this opportunity and a great collaboration to contribute the Hotspots data to the AURA 2021 report. Thank you.
Thank you very much. Thanks, Dr. Wozniak, for that presentation. We're now going to move to the panel discussion of part of the event. Thank you, everyone, for sending in your questions. We'll aim to get through as many as we can. And just a reminder that if you're on social media, that we would love you to tweet out anything about today's discussion. I'll give you the Twitter handles and everything in a minute. I'll just introduce our panelists. We've got 3 in Adelaide. I'd like to welcome back Professor John Turnidge, Dr. Morgan Warner, and a welcome for the first time today to Nadine Hillock. She's a public health pharmacist and the Program Manager for the National Antimicrobial Utilisation Surveillance Program, and she's responsible for the surveillance of antimicrobial use across 250 Australian hospitals. We're going to be bringing on a panellist in Perth soon, but I'll just go to our Sydney guest, who is Professor Anne Duggan, the Chief Medical Officer at the Australian Commission on Safety and Quality in Healthcare. She's a conjoint professor at the School of Medicine and Public Health at the University of Newcastle, and she's also a highly respected gastroenterologist with significant leadership experience in a range of healthcare settings. And we have joining us from Perth, Professor Jeff Coombs, the Chair of Public Health at Murdoch University. He's a Senior Clinical Scientist at the Department of Microbiology of the Fiona Stanley Hospital Network, the Chair of the Australian Group for Antimicrobial Resistance, and the President of the Australian Society of Antimicrobials. So we have a very esteemed panel joining us today for this discussion. So don't forget, if you're on social media, we would love you to tweet out anything in this discussion. You can follow the Commission. Their handle is ACSQHC, and mine is Sophie Scott and the number 2. And I think we're both on Instagram as well. If you're on Instagram, you want to tweet, put out any photos or comments. And don't forget, we've got about probably just over 20 minutes for the discussion. So we'll try to get through as many questions as we can. But let's get cracking. So first of all, let's start with what's in the report. So Professor Turnage, can you just briefly take us through what does the report show about antibiotic use in hospitals? What are we seeing in this latest report?
Yes, so the data that's coming from hospitals is very interesting. Using the traditional WHO measure that we have at defined daily doses per 1,000 occupied bed days, we've seen a sort of steady upward trend over the last few years, and we haven't really got to the bottom of what's driving all that. Nadine, my esteemed colleague running the program, tells me that there is improvement in data capture with inclusion of certain other indications and certain other specialties within the hospital, but that can't really account for the upward movement. And I'm personally concerned now that the measure that we're using isn't really telling us what we need to know. And I'm very hopeful that as we move into the future with electronic prescribing, we can get a much more interesting statistic of days of therapy. Once we have that data, I think we'll be much better informed about what's going on.
Interesting. And I might just go to you, Professor Duggan. Overall, how concerning is the data overall in this report in terms of antimicrobial use in Australia? What are we seeing on a sort of trend basis?
Well, I think we've looked at this in the Atlas of Healthcare Variation and where we've mapped it by where people live, and I think we've seen quite clearly overall high rates, but marked variation. So some people are doing it well, but also some people aren't doing it well, as previous speakers have pointed out. I do think that this is an enormous opportunity for us to connect up the dots. If you think about the opportunities with involvement of public health, then if we had lower smoking rates than 14%, we wouldn't have so many people getting COPD or CID. If we had better nutrition and housing for our most disadvantaged members in our community, we wouldn't have so many kids with otitis media. So Atul Gawande has just written a paper about the healthcare system in Puerto Rico, which shows that with their limited money and very good public health, they now have higher life expectancy than the Americans. I think we should be thinking about, this is a really difficult problem, but should we step back a bit as well and connect up to prevent disease as well as treat? If we don't have such high rates of obesity, we won't have as much diabetes. I think we need to think about ways of addressing this problem somewhat differently as well. And I think the third thing would be clinicians need to be taking responsibility, not just for the one-on-one consultation just now, but thinking more broadly as per their code of conduct. There are great opportunities, I think, and there's great work being done, more to be done.
Okay, excellent. We might go back to clinicians in a minute, but overall, I might just go ask Professor Coombs, overall the findings of this report, what does it tell us about how well we're doing to tackle antimicrobial resistance in Australia?
Okay, so I think we still have lots to do, and so I just look at one of the programs we do in AGAR, which is the Staphylococcal report, the ASOP report, and I think John Chernich mentioned that we're looking at the number of percentage of Staph aureus sepsis cases in Australia now around about 1 in 6 MRSA, and how that compares us to Europe, not particularly well. But if we drill down in that data a little bit more, we see that unlike Europe, most of our MRSA is community associated. It's actually not healthcare associated. So we've done a really great job, I think, in MRSAs in hospitals, but not so much in the community. So I think where should we be looking now? So one of the things is with community associated MRSA, where is the major problem? Well, I think that's also been discussed with the other speakers as well, that we have a huge problem with community associated MRSA in the northern parts of Australia, particularly the northwest of West Australia and the NT in northern Queensland. I think we need to focus a little bit more on that as well. With other MRSA, we look at healthcare associated MRSA. Our major clone, again, John mentioned the MRSA 15 ST22. And we know this is a huge problem in our aged care facilities. So we need to do some work on that as well. But the more newer part of the whole surveillance program, I think, is the livestock associated MRSA. And that was in the opening talk with the CMO, the acting CMO, talked about how AURA or AMR with the Department of Health is looking at the whole of health, so One Health. And we know that livestock-associated MRSA is an issue in Australia. And in the most recent AGAR surveillance program, we're actually seeing patients now with what's called livestock-associated MRSA infections, not just community-associated. But these are the three major areas I think we should be looking at.
Felt very interesting. And we've discussed this briefly, but I might just get Professor Turney to get you to reinforce about the impact that the pandemic has had on prescribing rates and what impact that had and what we need to do to ensure that it stays at the same, the gains we've made.
Very important question. Yeah, very important question, Sophie. This was a surprise. In fact, the report generally covers through to 2019, but because the Commission obtained the PBS data through to the end of 2020, our analytical partners at the University of South Australia say, hey, look at this. And there was clearly a very strong drop in antimicrobial use in April that remained sustained all the way through to December. It was clearly linked to COVID and all the public health measures that have been introduced, lockdowns and other variations, physical distancing, that have had a significant impact. And I guess if you wanted to think about it, all the educational efforts up through the last 20 years were slowly having a slow effect. This had a profound one. And maybe the message has got out. Nobody's just going to their doctor expecting antibiotics for COVID. And we just need to tell them that it also applies to a whole bunch of other viruses. I'd say that the only real tools in the toolkit that we have to make sure that this is sustained or even improved is to provide some educational resources both to the prescribers and the public. Education, as I said, was having a slow effect, but I think a reinforcement education program at this point would have a much more likely chance of succeeding, and we shouldn't lose that opportunity.
Good idea. So I might just stick with our Adelaide guest at the moment and ask Dr. Warner and also Nadine a question that I think is of interest, and that is, I think this might have been a question that came in from the audience. It said a high percentage of patients attending NPS medicine insight practices continue to be, and this is about appropriate use of antimicrobials. And the report found that that there were quite a number of people who were still getting antibiotics where there's no evidence of benefit. So there was more than 85% of people with bronchitis, acute bronchitis, and more than 80% of people with acute sinusitis were still getting antibiotics. How do we address this? Because clearly that's still, these areas are of concern. So I'll start with Dr. Warner and then maybe Nadine.
it's a big problem, and again, it comes to that expectation of receiving antibiotics for upper respiratory infections, and again, that's an education perspective. I think the COVID period really clearly shows that that people aren't getting antibiotics if they don't have respiratory symptoms, and that most of those respiratory symptoms were therefore virus driven. So I think being able to sort of link those data and sort of showing people the data, there was no influenza in Australia, and the presentations to GPs reduced, and that's because most of the respiratory infections are viral. So I think that message, we must use these data to help improve our practice. And again, we have to educate our GPs as well to try and bring out that message that viral infections don't need antibiotics. And also the hospital doctors, I must say.
Yeah. And Nadine, I might just get you to reflect to the same issue from your perspective where you sit.
Yeah, so from the hospital doctors, we've noticed actually with COVID that there was an initial sort of increase in 2020 in antimicrobial use in the hospital system, but then it sort of fell off during the year. So I think there was that, it was a combination of reduced patient numbers in hospital as well, but over the year, but also I think although there was that initial surge in antibiotics at the start, it fell off during the year, which was really pleasing to see. We still did see some increase in third and fourth generation cephalosporins, so the broader spectrum ones, which is still concerning. So there needs to be, I think, probably more focus on that and drilling down to see why that's still happening. But yeah. Great.
And I want to stick with a couple of audience questions. One that came in was, what I might just get Professor Coombs to answer this one. What would you suggest someone do? And this is for people who have patients with regular urinary tract infections. What can we suggest for those people who might require antibiotics to treat the condition? Wait until there's an infection, or is it better to look at alternatives for things like recurrent UTIs? Professor Coombs or maybe Professor Duggan might as well like to answer that. Do we need to be thinking about those regular alternatives to antibiotics, for example, for things like recurrent UTIs? Professor Coombs? I'm not hearing Jeff, but Professor Duggan, I might get you to jump in and answer that one if that's all right.
Well, I think the first thing is really important to diagnosis is the crux. I mean, I think we over-treat what we think are urinary tract infections when they're not a urinary tract infection, and there's good data. So I think that's a body of work that the Commission recognises it should do and will do in terms of improving diagnosis, so we're not inadvertently exposing people to unnecessary antibiotics. I think that's the first step.
And there are some other prophylaxis things that, like, I just remember doing a story in the past. I know sometimes in residential aged care they'll give people who live there a medication called Hiprex and vitamin C, that's been shown to actually reduce the incidence of recurrent UTIs in nursing home residents just as a prophylaxis. There's just a little bit of inside information that I remember doing a story on that was very helpful. One thing I want to come back to, which was mentioned earlier, was and it's an audience question, how do we better engage primary care and also consumers with the concept of antimicrobial resistance and quality use of antibiotics? So I might go to Professor Turnage. How do we better leverage the good results we've had so far, particularly with primary care and also with consumers and patients, so that they get on board and make sure we don't go back and in terms of go back to the inappropriate use of antibiotics? Professor Turnage, then maybe we'll go to Professor Coombs who's come back online, but we'll go to John first.
Yeah, thanks, Sophie. Look, this is a really important question, and it's been troubling the minds of all of medical profession for the last 20 years. There are a number of tools in the toolkit that we've been offering GPs over the years, and they need the tools, they need the defence tools for the patient who thinks they absolutely need antibiotics for their cold or their sore throat. And that things such as delayed prescriptions, where the prescription is written but only told to fill out if it actually gets worse. And that's a strategy that came out of the UK, was trialled and shown to be effective, but not terribly effective. Most prescriptions don't go on to be filled, and we don't have a way of measuring that in this country in our current system anyway. I'd say that the tools in the toolkit are sitting there, and we've just invented them. COVID is probably the biggest tool in the toolkit we've ever come up with, saying, hey, this is fantastic virus. You know how we manage it? You go get a test, you know what it is, you just go home, you stay home and take all the supportive medication you need, but you don't need antibiotics. And GPs can deliver that message very quickly in all the languages we need. I think that's where we seriously need to go as getting to sustain the drops in antimicrobial use and get even further drops, because even with the drops, we're still well above countries like the Netherlands, which we'd otherwise like to compare.
So I might, we've sort of only got about 5 or 7 minutes left, so I might just move through our other questions and maybe go to Professor Coombs with this next one from the audience, which is, how can we ensure that GPs and aged care homes follow the recommended antimicrobial advice when managing infections in our older generations? And this audience member said it's difficult to get GPs to use information that they might see if they're going around from different hospitals and different aged care centres. So what would your advice be? How to get GPs and aged care homes on board with the recommendations about managing the use of antibiotics?
Okay, so I'm going to really handball this one. Sorry, Sophie. I think probably more John Turnage is probably more appropriate or relevant to answer that one, being a scientific-based person, not a medical. So, John, I'm going to handball it to you, if that's okay.
All right, John. Back to you, John.
And should I handball it to Morgan? No, I won't do that.
All right. Well, we'll ask Morgan the next one.
Okay, ask Morgan.
Yeah, that's fine. That's fine. I'm quite happy to deal with that. This is a big issue that hasn't really been teased out yet, but the aged care sector is now aware of the fact that there is a huge amount of variation in antimicrobial prescribing, and we have from the aged care national surveys the data to support that there's a lot of unnecessary use in GP land. That example that you brought up earlier, Sophie, of UTIs in the aged care sector, is because a lot of people are confused by the concept of asymptomatic bacteriuria. It's quite common for the elderly to have bacteria in their bladder and not cause any symptoms at all. But if you test them, they'll pass the laboratory test for having a UTI. So once you see that result, you can't resist treating them. And it actually causes more problems than it solves. The evidence for Hiprex actually preventing serious symptomatic UTI in that setting is quite small, non-existent really, but it certainly it takes you out of the antibiotic sphere. But there are other issues in aged care sector, inappropriate use of treating red things on people's skin with all sorts of topical antimicrobials, and that's another very important area. It's really good that we've got the Aged Care and Safety and Quality Commission going. We're now starting to get the tools to look into the sector and provide the guidance that they need to stop unnecessary prescribing.
So we're madly running out of time, but I want to get to a couple of quick questions. So I'm just going to do some quick questions to get through as many audience questions as possible. One question from the audience was for Nadine. What key role can you see for hospital pharmacists in preventing antimicrobial resistance in the future? Nadine?
Yeah, no, I think pharmacists have got a real pivotal role in sort of the stewardship sort of sphere, writing guidelines and reviewing medications in the hospitals, but also in the community. Their role's getting bigger and expanding as well, educating GPs. particularly in rural areas. That's where pharmacists can play a huge role, where there's maybe not so much ID support available. I think that it's just, there's been, during COVID actually, there's been pharmacists sort of taken off antimicrobial stewardship to go and do vaccinations and things like that, and it's noticed that being a real problem to try and keep surveillance and stewardship going. So I think pharmacists can play a huge role.
And we might just thank you for that, and maybe one for Jeff and for Morgan, another audience question. What are the benefits of pathogen genomics in helping antimicrobial resistance? So maybe Morgan first, and then Jeff.
Yep.
Look, I think this is actually more of a Jeff question, to be honest. But
Morgan, I'm happy to answer it if you want. That's fine.
Sorry, what's that?
Okay, so
you go ahead.
Okay, yeah, it's huge actually. It goes back to the story I was saying with the livestock-associated MRSA issue that we're now having. And so by using, when we sequence these organisms, we know that not all strains are livestock-associated. Some are human problems, and we're writing up a particular paper with Morgan at the moment actually on CC398. And so whole genome sequencing is able to distinguish between livestock and healthcare associated or community associated MRSA. So it plays a really important role actually.
Interesting. So you can you can get a lot more information about where things have come from, and then you can work out where to target your actions in the future. So look, we're pretty much out of time, but I wanted to just go briefly around to each of the panelists and ask them what's the single most important message for action as a result of the AURA 2021 report. And maybe Jeff, will start with you, given we're with you. From your point of view, what do you think is the single most important message for action that you would like to see people take and the healthcare community take as a result of the findings of this report?
Yeah, I think we've got to start thinking One Health. And I think that was the opening talk. I mean, we've been very focused now on human health, but we can see from the work that we've been doing, from just even the AGAR surveillance programs, that it's more of a One Health issue, and we have to bring on the animal people as well as the human people.
Great idea. And I'm going to go to our Adelaide panellists to get their point of view before I go to Sydney. So we'll start with Nadine. What would you like to see as your biggest single most important action you'd like to see as a result of what you've read in this report?
Yeah, I think the timeliness of data, data is so powerful, and if we could just expand data, where those gaps are, and able to sort of present it back to the people that need it in a timely manner, I think that's the single most important thing I think is going forward would be helpful. Okay, and Professor Turnidge?
Oh, I think I've been gone about it too much, but COVID, we did deliver some gigantic benefit, and we need to do everything in our power to continue to reap that benefit, basically.
And I think your example of showing that we can have a serious illness that doesn't need antibiotics to treat, or to treat it, just supportive care can make a big difference. And Dr. Warner?
Yes, look, I think the AURA report really has given us a rich source of data to be able to look at our antibiotic usage, our resistance rates, and also how well we are appropriate. Clearly, some things have not decreased as much as we would like, and I think the data is just a start. You have to go in and you have to really analyze your own unit, see where your problems are, and do your own little audits. The data really is a great thing. Our electronic systems in hospitals will help. Doing a NAPS type of audit of appropriateness, on a weekly basis rather than a yearly basis, would be very helpful to get that granular data. So I think it basically improve getting our hospital systems to work better for us.
Okay, excellent. And now we'll go to Sydney. We'll go to Professor Duggan. What would you like to see as the key action from this AURA 2021 report?
That all prescribers of antimicrobials look at the data and think seriously next time they're in a consultation about not only the patient in front of them, but the implications of what they're trying to do and think seriously about is a prescription needed in this situation. I think we really do need to stop thinking just about the patient in front of us, the whole implications of what we do. We are the custodians of the community's health.
Excellent. That's a great point to end that discussion on. So thank you so much to all our panellists. I'm sorry we didn't get to all the questions, but we probably would be here for another 2 hours if we had a lot of interest and a lot of questions, but it's been a fascinating discussion. So thank you very much to all of our panelists for an amazing discussion. We really appreciate your thoughts and insight. As always, it's been absolutely fantastic. So as you've heard, and you've heard from all the speakers today, and as we delved into a little bit in the discussion, there's been some really good steps forward in the fight against antimicrobial resistance. But there really is more that needs to be done. And I think particularly Professor Turnage, what he was saying is we can't step back, we can't lose this ground that we've gained from the pandemic. You know, we have to, I guess that one good thing from the pandemic has been this drop off in the use of antibiotics. And it really is up to everybody. It's up to patients, clinicians, policymakers, leaders in healthcare, journalists and the media to make sure that we don't overuse antibiotics in terms of and use our spheres of influence to make sure that we continue to make improvements in this area because it's such an important public health measure. So I'll now, given that we're running a little bit over time, I'm going to hand back to Professor Willis-Marshall to officially launch the report, AURA 2021. Please welcome back Professor Marshall.
Thank you. As Chair of the Australian Commission on Safety and Quality in Healthcare, I'm acutely aware of the incredible challenge that the COVID pandemic has placed on Australia's healthcare system. Never before has there been such a pressing need to ensure our health system is providing the most effective, efficient and safe care possible. However, it is quite curious that from the COVID you've heard today, it may give us important new understanding about how we can use antibiotics in the management of infection. AURA 21 is the fourth national human surveillance report and continues to provide an expanding picture of antimicrobial resistance and antimicrobial use in Australia. AURA reports are one component of the Commission's work to prevent and control antimicrobial resistance by reporting on analyses of data collected for the AURA surveillance system and promoting the appropriate use of antimicrobials. Today we've heard from the Australian Government Deputy Chief Medical Officer, the Commission AURA's partners and clinical experts about how these data inform policy and practice and the challenges that we can all work together to address. My sincere thanks to the speakers and the panel. I want to acknowledge with thanks all those who have contributed to the development of the AURA surveillance system and the data that sustain it. Many of you are in the audience today, and I am confident that you will help AURA 2021 and the help AURA 21 will be of great benefit to all of the Australian community. I also want to thank the AURA team at the Commission who established the AURA surveillance system back in 2013 and have ensured a strategic and a coordinated approach to its ongoing development. Well done. I would like to challenge clinicians and health services right across Australia to continue to contribute to the AURA surveillance system and to consider what the findings of AURA 21 mean to you and identify what you can do to improve and to be engaged with the system and to continue to improve our outcomes, because without the cooperation, the support of the medical profession, we will not make the changes that we so desperately need to do. Once again, thank you all, and I'm pleased to officially launch AURA 2021, and thank you all for joining us today.
Thank you very much, Professor Marshall, and thank you very much for launching the report. And it's such an important document. We delved into it a little bit, as much as we could in the time we had, but I really encourage you all to read it in detail. And thank you for being here. Now, the Commission will send a recording of today's event to anyone who's missed it, if you'd registered for it, and you'll also be able to find this recording on the Commission's website as well. So thank you very much from me, and I'll see you next time at the next report. But that's all from me. Thank you very much. Goodbye.